Greetings, students of RESP 2570. Our next topic, respiratory alkalosis. This will be the second of our 4 blood gas disturbances that we will be examining. This information can be found on page 340 in MALI. I would like to offer a second title for this presentation, and that is, Why is my patient breathing like that? When respiratory alkalosis is the blood gas classification, it should amplify the respiratory therapist's assessment to determine the etiology for this blood gas disturbance. I'll try to provide some illustration of this as we move through the material. So, respiratory alkalosis is a common acid-base disorder. Presents with, if it is prolonged, renal compensation where decreasing bicarbonate levels would appear over that 48 to 72 hour period. There's profound effect to the cerebral blood flow, and a decreased cerebral blood flow occurs when CO2 levels drop. This is a substantial response and is particularly important in individuals who have traumatic brain injury or who are at risk for increased intracranial pressure. The cardiovascular response is that pulmonary vascular resistance can increase. Arrhythmias can develop due to decreased coronary blood flow associated with the pulmonary vascular resistance elevation. This would be of particular concern in patients who have pre-existing ischemic heart disease. Recall that in our last presentation, Mali had showed us a graphic that explained the etiology of the blood gas disturbance in question. He's done this also for respiratory alkalosis. We'll work our way starting at the 12 o'clock position and work clockwise to explain this illustration. So note, the central nervous system plays an important role in the regulation of patients' CO2 homeostasis. The central chemoreceptors located in the medulla are principally sensitive to CO2. CO2 crosses the blood-brain barrier, changes the pH of the CSF, and the CSF influences the medullary centers. This will promote a proventilatory response. It'll attempt to increase alveolar ventilation to maintain CO2 levels at a homeostatic level. This is the principal neurochemical drive to breathe. Recall that ingestion, whether intentional or inadvertent, various chemicals can promote acidification of the CSF and influence respiratory centers. Some toxication can promote this as well, and we'll try to identify those as we discuss this curriculum. Various physical and emotional stimuli can promote an increase in alveolar ventilation, resulting in respiratory alkalosis. This may be due to receptor stimulation or central nervous system override of other respiratory centers. Peripheral chemoreceptors are located in the aortic arch and the carotid bodies. These are principally responsive to partial pressure of oxygen. As a patient becomes hypoxemic, then stimulation of the peripheral chemoreceptors will promote an increase in alveolar ventilation. This is important to recognize that hypoxemia can be an etiology for respiratory alkalosis. Also, reduction in blood pressure can influence baroreceptors and produce a soft response to increased ventilation in the presence of hypotension. Thoracic cage abnormalities and deformities can also promote respiratory alkalosis. This is through a variety of receptor stimulation that we'll explain as we move through the curriculum. Also, in the lungs, there's a variety of pulmonary reflexes that could be stimulated as lung conditions change. This will be stimulating an increase in alveolar ventilation and producing respiratory alkalosis if those mechanisms for ventilatory response are intact. Ingestion of various drugs such as aspirin in overdose can promote respiratory alkalosis, even though a profound metabolic acidosis will commonly develop. The dominant or observed blood gas disturbance in the case of aspirin OD may be respiratory alkalosis, and I'll show you some case information on this. Mechanical ventilation may be targeting a higher ventilation or alveolar ventilation promoting respiratory alkalosis. So if we're adjusting mechanical ventilation, what is our target? In rare occasions, we will provide intentional alkalinization, but in most cases, we target CO2 homeostasis. And as I mentioned in the last presentation, occasionally we target permissive hypercapnia, allowing CO2 to increase and pH to drop. Inadvertently or inappropriately applied mechanical ventilation may prescribe too high of a minute ventilation, and that itself may promote respiratory alkalosis. So if respiratory alkalosis is present, was it intentional or is it inadvertent? We may have to adjust our levels of ventilatory support. So here is a mini case for URT students. A 45-year-old male is on the medical surgical ward post-op cholecystectomy. Cholecystectomy is removal of the gallbladder, likely due to cholelithiasis, gallstones, or cholecystitis, inflammation of the gallbladder. You enter a room for a routine post-op assessment as the patient has had abdominal surgery. Abdominal surgery patients are at high risk for respiratory deterioration because people tend to splint due to abdominal pain. They don't breathe adequately. They don't deep breathe and cough, so they're prone to developing post-op complications, including pneumonia. When you walk in to view your post-op cholecystectomy patient, you notice that they are tachypnic. Recall that tachypnea is an increase in respiratory frequency. That does not necessarily mean that they are hyperventilating. You provide rapid assessment, and as part of that assessment, you draw arterial blood gases per your department policy. The arterial blood gas reveals the following: pH 7.53, PCO2 22, bicarb 22, PO2 of 50. Interpret the arterial blood gas and what is the etiology or suspected etiology for the disturbance. In this case, what we noted when we classified our blood gas, their classification results were uncompensated respiratory alkalosis with moderate hypoxemia. Arterial hypoxemia leads to peripheral chemoreceptor stimulation. This stimulates respiratory centers in the medulla. A PO2 decrease in the range of 60 to 30 millimeters of mercury. That's the range where stimulation of the peripheral chemoreceptors occurs. Maximum stimulation, so there is a greater response in the 40 to 60 millimeter mercury range. Either way, the patient is hypoxemic. The position of the peripheral chemoreceptors is the aortic bodies located in the arch and the carotid sinus at the bifurcation of the carotid vessels. So when you see respiratory alkalosis, closely inspect your oxygenation. So with regards to the classification, what I've shown you here is just the text box method where we're identifying the OSIS and the EMEA and looking at how each parameter associated with acid base affects the pH. This should be a pretty straightforward way to classify. Follow the ABCs of ABG classification. We also noted that moderate hypoxemia was present based on the thresholds of the various classifications of hypoxemia. Now I'm just providing a competing text box to show you the respiratory alkalosis etiologies versus respiratory acidosis. So this will serve as a bit of a reminder in comparing the blood gas disturbances. Remember, respiratory alkalosis is a low CO2 unopposed. It will cause an increase in pH. Respiratory acidosis is an increase in hydrogen ion caused by an increase in CO2 due to inability to maintain adequate alveolar ventilation and CO2 homeostasis. So let's just compare the etiologies. Respiratory alkalosis, hypoxemia. I just showed you hypoxemia in that last mini case with the patient with cholecystectomy. But additional etiologies can be pulmonary reflexes, neurologic causes, infection and sepsis, hepatic failure, and inappropriate mechanical. Respiratory acidosis, as we recall, was broken into acute and chronic categories. Central nervous system depressive agents, so pharmaceuticals or other agents that may be ingested or injected that can adversely influence patients' alveolar ventilation. Neurologic disorders, neuromuscular disease, and drugs that affect the neuromuscular junction. Respiratory muscle fatigue in patients vulnerable to increasing ventilatory workloads and the inability to sustain it. Extreme VQ mismatch and situations of excessive CO2 production, usually in combination with pulmonary dysfunction. Chronic examples would be COPD, neuromuscular disease, thoracic cage deformities, and mechanical vent that may be inadequate based on the patient's settings versus their pulmonary dysfunction. So remember that control of breathing is neurochemical in nature. Higher center override can occur. So the most powerful force to control CO2 homeostasis is the central chemoreceptor response to carbon dioxide. We'll provide other examples of these neuronal, chemical, and higher center influence on breathing. The central chemoreceptors I've already mentioned, but here's a bit of a review, likely similar to what you would have experienced in RESP 1690. So the most powerful influence to breathe is CO2. The central chemoreceptors respond to increases or decreases in hydrogen ion concentration. That's in the cerebrospinal fluid. We'll have a reminder of how CO2 crosses the blood-brain barrier to influence this. Cells in the medulla oblongata, so the medullary central chemoreceptors, an increasing hydrogen ion concentration of the CSF results in increased ventilation. The lower buffering ability of the cerebral spinal fluid is partially responsible for this. As hydrogen ion increases rapidly in the CSF, that means that you can have a very instantaneous response to that CO2 level, and alveolar ventilation will increase. There's a cyclic and continuous influence on CSF pH, and that allows the very responsive central chemoreceptors to influence the CO2 levels in the body by promoting an increase in alveolar ventilation when CO2 escalates. Okay, what we see here is the ventral surface of the medulla oblongata. Central chemoreceptors are noted on either side. This model shows us the blood. Remember that the blood-brain barrier is a protective barrier that does not allow all substances to easily cross into the CSF. This is a protective mechanism. But what we note is hydrogen ion is relatively impermeable, bicarbonate is relatively impermeable, but CO2 is readily permeable to the blood-brain barrier. CO2 moves across, CO2 enters the hydrolysis hydration equation and ends up manufacturing hydrogen ion. So if CO2 is increased, the hydrogen ion will be increased, and that is what affects the CSF pH that has a prostimulatory effect on the central chemoreceptors. Please note that I have provided a PDF readout of the blood-brain barrier that is necessary for the student of respiratory therapy to review. So recall that the blood-brain barrier is a protective mechanism that provides a stable environment for the brain. It keeps blood separate from the cerebral spinal fluid. It's a selective rather than an absolute barrier, but when there's injury or maybe vascular disease or central nervous system structure disease or violation of those structures, then the patient would be vulnerable to substances that are normally closely regulated being able to pass the blood-brain barrier. Please review the document that I've included in the respiratory acid base file, and that will provide you with some reading and serve as a resource for understanding this structure and the mechanisms involved. Just a quick review of the peripheral chemoreceptors, since we've had some more extensive dialogue on central chemoreceptor response. So we looked at this a few slides back when we looked at hypoxemia as an etiology for respiratory alkalosis. Peripheral chemoreceptors are oxygen-sensitive cells located in the bifurcation of the carotid arteries and in the aortic arch. Cranial nerves 9, glossopharyngeal nerve, and cranial nerve 10, vagus nerve, are responsible for the innervation to the respiratory centers from these peripheral chemoreceptors. Stimulus is a low PaO2 and subtly a decrease in arterial pH. So decrease in oxygenation is a stronger of the stimuli for the peripheral chemoreceptors. The response, if they're stimulated, they will increase ventilation. That's providing that those mechanisms are intact, because some people will be in such a debilitated state that despite stimulus occurring, they may not be able to increase their ventilation. Those people are severely deteriorating and would, of course, need some assertive intervention in order to stabilize them. A synergistic response occurs due to hypoxemia and acidosis with regards to the peripheral chemoreceptors. But again, remember, acidosis is a softer stimuli. Neurologic control over ventilation, and in this case, I've put it into a text box just to help you with your preparation. Peripheral chemoreceptors, glossopharyngeal and vagus nerves being the innervation route, decreased PaO2, decrease in arterial pH, and a synergistic response, hypoxemia and acidosis. Central chemoreceptors, principally responsive to increase or decrease in hydrogen ion concentration in the CSF. Cells in the medulla oblongata are stimulated, and increase in ventilation as CO2 escalates. Remember, CO2 crosses the blood-brain barrier, changes the hydrogen ion concentration in the CSF. Increasing acidification of the CSF will increase ventilation. Pulmonary reflexes that should be explored at this point include stimulation of J receptors can lead to respiratory alkalosis. This is an important pulmonary reflex. Certainly, we're going to see this in our critically ill patients. Juxtapulmonary capillary receptors are located in small conducting airways, blood vessels, interstitial tissues, in and around the pulmonary capillary and alveolar walls. When stimulated, tachypnea and hyperventilation will develop. We have to look at those carefully. Tachypnea may cause hyperventilation, but tachypnea is an assessment of the patient's respiratory frequency. Hyperventilation, we need to examine what is occurring with regards to the patient's PaCO2. Did the hyperventilation promote enough alveolar ventilation to drive the CO2 down? This may be a subtle stimulation or reflex that, when stimulated, promotes respiratory alkalosis. Think about where these are and think about what can stimulate them. Okay, J receptors are stimulated by increase in interstitial fluid volume, chemical irritants, and microembolism. Pulmonary edema and pulmonary embolism will stimulate J receptors, promoting respiratory alkalosis. Fibrosis, so histologic alteration of those structures of the alveolar walls, the interstitial structures, and the pulmonary vasculature can promote the stimulation of J receptors. Pneumonia can also stimulate them. So when we think about those, as we see respiratory alkalosis developing and the patient's breathing pattern changing, then we've got to be suspicious that something is occurring. And particularly when there's changes in the pulmonary, maybe even relatively undetectable changes in increasing edema at an AC level, that can be a motivator for a changing ventilatory pattern and development of this condition. So my caution is always consider whether J receptors are the causative receptor. Think about their location and mechanisms of stimulation. So here's a mini case. You're assessing a patient who's being treated for acute pancreatitis. He's being managed in the ICU on mechanical ventilation. 4 hours previous, the patient's total ventilation on pressure support ventilation was 8 liters per minute with a normal PaCO2. Now the patient's VE is 12 liters per minute with respiratory alkalosis. No clear reason for the alkalosis. What do you suspect? Well, let's take a look at his etiology. The etiology for his maybe tour of duty in the intensive care unit and or admission to the intensive care unit is pancreatitis. Pancreatitis, just by looking at the medical term, is inflammation of the pancreas. This can occur for a variety of reasons, but the pancreas can produce a variety of enzymes that early activation, overproduction, and liberation of these substances can create an autodigestive process where the early activation will start eroding the pancreatic acini. It can be associated with substantial liberation of inflammatory mediators as well. So, in that case, when we think about a situation like this going, we can get a SIRS septic like picture, and the patient could be also having hypoxemia. They could also be having um, uh, situations of edema formation in the lung, so all kinds of stimuli for a changing ventilatory pattern. The subtle changes as edema is taking place in the lung could be an early example of why their ventilatory pattern is changing. So the patient is being managed in the ICU on mechanical ventilation, and over the course of a short period of time, his minute ventilation changes, and respiratory alkalosis is the blood gas disturbance. I would be suspicious of this. Minute ventilation increases indicate a change in respiratory status. Likely, respiratory alkalosis will result and might be the early blood gas disturbance. Etiology for the altered gases, think about what we've talked about so far. Try to put that together. Certainly, abdominal pain may be part of this, and inflammation of abdominal structures can be very painful. That itself could stimulate the patient to change their ventilatory pattern. Sudden pain usually causes apnea. Continuous pain usually causes an increased respiratory frequency, and that can lead to respiratory alkalosis. Exacerbation of the disease, so worsening of the disease process, it's a pro-inflammatory disorder. Uh, Lots of liberation of inflammatory mediators, and the edema could start to stimulate things like the J receptors. So pulmonary edema, look for evidence. A recent chest film, has there been changes? Maybe you call for an additional chest x-ray at the point of deterioration to see if there's been any pulmonary changes occurring. Altered blood gases without obvious or maybe very subtle discrete indicators, uh, J receptors can commonly be implicated. Hypoxemia. What is the PO2 and saturation of this patient? That could be a clear reason. And certainly, as somebody gets more pulmonary edema and their lungs are becoming edematous, then oxygenation may drop, because what we can see is usually decrease in compliance, increased work of breathing, and the stimulation of peripheral chemoreceptors if the PO2 falls within that threshold of stimulation, could be the motivator for a changing ventilatory pattern. Baroreceptors, if the patient's hypotensive, that's a soft response, but could also be part of this clinical picture. So, J receptors, hypoxemia, baroreceptors may be a synergistic response, as all those receptors are being stimulated to promote a change in alveolar ventilation and development of respiratory alkalosis. Peripheral proprioceptors are sensors that are located in muscles, tendons, joints, and associated with pain. Stimulation sends a message to the medulla, stimulates inspiratory signals. Pain and movement can stimulate inspiration. Sudden pain, as I mentioned previously, can promote apnea. Prolonged pain usually promotes tachypnea. Proprioceptors in joints and tendons can increase respiratory rate during exercise. Baroreceptors, as I mentioned previously, located near the chemoreceptors, the peripheral chemoreceptors that is. They can regulate rate and depth of ventilation with changes in cardiovascular function, increase heart rate and ventilatory rate with drops in blood pressure, and decrease heart rate and ventilatory rate associated with increase in blood pressure. Hypotension can induce respiratory alkalosis. Pulmonary reflexes that additionally promote the development of respiratory alkalosis include receptors responsible for lung deflation, and examples of that include the Herring-Brewer stretch receptors. These are located in smooth muscle of conducting airways in the bronchi and bronchioles. They're stimulated by changes in lung volume during inflation and deflation. They will inhibit inspiration when the receptors are stretched, such as during periods of overinflation. This provides a feedback mechanism to terminate inspiration. This can have a protective advantage because it can prevent lung damage via overinflation, particularly during adverse respiratory mechanics. A respiratory pattern that would show an increased respiratory frequency and decreased tidal volume would occur in times when lung compliance is decreased. The Herring-Brewer receptors are not normally active. Deep breathing will normally inhibit inspiration at larger tidal volumes. Thoracic cage deformities can also lead to an altered breathing pattern, and this provides some additional explanation as to the ventilatory pattern and the changes in blood gases that can occur in thoracic cage abnormalities. The receptors are described as slow reacting receptors. That means that the influence continues as long as the stimulus is present. An additional receptor is Head's paradoxical reflex. This is a rapid acting receptor. It stops the influence once the change occurs. This can be responsible for large tidal volumes during exercises. The inflated lung is stimulated to increase respiratory effort. This information came from Beachy, the cardiopulmonary anatomy and physiology text commonly used in RESP 1690. Check the version for the current page number. So deflation reflex, so this is inflation, deflation receptors. Some mechanisms are not clear, but they're described as slow acting receptors where the influence continues as long as the stimulus is present. They stimulate inspiration at low lung volumes. Compressed or deflated lung results in an increased rate of breathing. Irritant receptors can also influence respiratory pattern and perhaps initiate respiratory alkalosis. They're located in the epithelium of large and conducting airways, trachea, bronchi, and bronchioles. They're stimulated by inhaled irritants and as well by mechanical stimulation. So physical stimulation can promote a change in ventilatory pattern. Stimulation results in change in ventilatory rate, and that would be an increase, bronchoconstriction, as well as cough, sneeze, tachypnea, and glottic tone changes can also be involved with these. Remember this is an important message for this presentation. Conditions that result in respiratory alkalosis can lead to respiratory acidosis. Alkalosis versus acidosis will depend on the severity of the disease and whether it is an acute or chronic process. So, allow me to illustrate. When you see respiratory alkalosis, look forward. Think about the pathogenesis of the disease process present. what is occurring that is promoting the respiratory alkalosis. Review the etiologies that we have discussed. Try to implicate one or more of these as causes of the blood gas disturbance. Respiratory alkalosis often is an early signal that if intervention, improvement, and the intervention may be medical or interventional, if we don't get a handle on the patient's ventilatory pattern and the etiology for it, respiratory acidosis may eventually manifest. It's an early warning to the RT that something abnormal is occurring. So that's why you really want to know the etiology in your patient's case for respiratory alkalosis. Looking forward, respiratory acidosis may develop. This is a super duper important concept. Neurologic causes of respiratory alkalosis can include anxiety and pain. We talked about sudden pain resulting in apnea, but continuous pain is going to result in respiratory alkalosis, change in ventilatory pattern, and hence a change in alveolar ventilation. Emotional stimuli can result in significant respiratory alkalosis. A rapid onset of change in ventilation. Remember that CO2 will be blown down. If cessation of breathing follows, it's because there is not a central chemoreceptor stimulus to breathe, because CO2 would be low. So there may be a period of time that goes by that until the CO2 normalizes, and then will start stimulating the central chemoreceptors. Higher respiratory control centers can override the normal neurochemical drive to breathe. This can include patients who are anxious about hospital procedures, stress, pain, fear. I put in visa bills of a respiratory student, letters and inquiry from Revenue Canada, money or the lack thereof, and as well U.S. presidential election results. So, additionally, in these text boxes, I'm showing you some etiologies for respiratory alkalosis. Hypoxemia is stimulated via peripheral chemoreceptor stimulation. Drop in PO2 is the prime stimulus for peripheral chemoreceptors. If hypoxemia is present, then it may be stimulating the patient to increase their alveolar ventilation. Overzealous mechanical ventilation. This is implicating mechanical ventilation. Is ventilation inappropriate? And that could be positive pressure ventilation in an intubated ventilated patient, or it could be due to an over-application of manual ventilation. Iatrogenic alkalosis can develop, and remember that may have some non-favorable results on the patient's cardiac status and with regards to their cerebral blood flow. Head injury is where sometimes we use adjustments in ventilation to provide a slight adjustment of blood flow to the brain. This needs to be carefully monitored. We would be following very specific protocols for this type of management. Intentional alkalinization sometimes occurs in patients, but we would readily identify those states, and we would need to be operating under therapist-driven protocols that guide our decision or decision support tools when we're applying this. Restrictive lung disorder can promote respiratory alkalosis. This is because of stimulus of reflexes, and so this serves as a bit of a review. Fibrosis, ascites, thoracic cage deformities can all promote respiratory alkalosis, right? Think about some of those mechanisms: stimulation of reflexes, J receptors, right? Inflation deflation receptors. Third trimester pregnancy, we can see dyspnea, um, respiratory alkalosis can develop in the late stage pregnancy. Also, the influence of hormones that can influence respiratory centers. ARDS, congestive heart failure, pulmonary emboli, and pneumonia, some of the early changes before respiratory acidosis develops may be the development of respiratory alkalosis. J receptor and peripheral chemoreceptor stimulation could be implicated. Neurologic origin, we can see respiratory alkalosis develop situations of fever, anxiety, and CSF acidification. Additionally, drugs and hormones, salicylates or aspirin, can acidify the pH and lead to respiratory alkalosis. Aspirin is lipid soluble and can cross the blood-brain barrier. Progesterone, female hormone, increases the sensitivity to CO2 of the central chemoreceptors and can promote increases in minute ventilation. Doxapram, a medication that stimulates peripheral and central chemoreceptors as a respiratory stimulant. Infection and sepsis can promote this. Systemic infection can lead to respiratory alkalosis. Mechanism, some sources put a question mark on this, but I think it's relatively easy to look at. Infection and sepsis can result in edema formation, J receptor stimulation, hypoxemia that may develop can stimulate the peripheral chemoreceptors. Toxic substances can also be produced that can stimulate central chemoreceptors. I've already mentioned the adjunctive hypoxemia that can accommodate these or accompany these conditions, pulmonary edema, and even it may be subtle. Obviously, when it becomes extreme, then we're more likely to see respiratory alkalosis or acidosis when VQ mismatch happens. Hypotension can also provide that soft stimulus as well. Hepatic failure. Some sources say mechanisms unknown, but I think it's explainable. Could be in relation to buildup of various toxins and how they promote abnormal brain and chemoreceptor response. Adverse effects on respiratory centers. Metabolic alteration could be part of this clinical picture, and the etiology for the development of adverse respiratory patterns. I think it's easy to explain when we look at edema that could be occurring with the decreased plasma proteins, changes in intravascular oncotic pressure gradients, fluid leak to the extravascular space, and the resulting edema can stimulate things like J receptors. Concomitant hypoxemia and hypotension can additionally affect this. So I think there's lots of explanation on hepatic failure promoting this. Shock and situations of decreased cardiac output. Peripheral chemoreceptor stimulation could occur with changes in the PO2 and the drop in pH. Vasomotor center stimulation can occur, and we know that hypotension that occurs in these situations can promote this. Edema formation can accompany these states as well as the hypotension, and so we get additional events that can cause an attempted increase in alveolar ventilation. This may not be sustained for a long period of time because the patient is in a severely debilitated state. Respiratory and metabolic acidosis may follow. Recall that CSF acidification can promote an increase in alveolar ventilation based on the change in CSF hydrogen ion concentration and its influence on central chemoreceptors. Physiologic or physical changes that can promote alkalosis. A tumor or brain trauma, so thinking about central nervous system disorders, can create a variety of stimuli that can promote a change in ventilatory pattern. These may be associated with increase in intracranial pressure, physical changes and interference with inhibitory mechanisms, and as well neural and endocrinologic influence can be altered in situations of brain tumor or trauma. All of these may result in a change in ventilatory pattern, change in alveolar ventilation, and development of respiratory alkalosis.